Welcome to Healing the Tigress, a podcast of stories and conversations on Asian American Pacific Islander maternal mental health. We are your hosts, Peggy, a licensed clinical social worker and certified breastfeeding peer counselor,
and Jasmine, a clinical pharmacist with a perinatal mental health certification. Both of us are Taiwanese American mothers and survivors of postpartum depression and anxiety.
We don't know about you, but we didn't grow up talking much about mental health in our families, and we want to change that now that we are mothers.
Together, with our clinical backgrounds and passion on the subject, we want to create a safe space for the AAPI community to discuss perinatal mental health issues.
And together, we want to break generational cycles in our own parenting journeys so that we can heal our inner tigress, a nod to the tiger moms before us. We are so happy you're tuning in here. Let's get started.
Before we begin our episode today, we want to remind our listeners that this podcast is not a replacement for professional medical advice or therapy. The expert we have on today will share some of her knowledge, but please remember that everyone's recovery journey will be different and that you should consult with your provider for your personalized treatment plan.
For Maternal Mental Health Month, we really wanted to have a discussion about medications and the role they can play in recovery. We also wanted to dispel some myths and misconceptions about medications so that folks in the AAPI community might feel more empowered or comfortable when discussing medications with a provider.
I can personally speak from experience that as someone who has studied medications in pharmacy school, it's still very scary being on the patient side of things. And things that I thought I knew, I wasn't even sure I could trust. So medications actually played a huge role in my recovery though, and I am forever grateful that I finally found the right psychiatrist to make me feel comfortable and guide me through using them. So for this episode, we really wanted to feature an AAPI perinatal psychiatrist on our show to help talk through some of these medication topics. And joining us today, we have Dr. Nia Dhand, who is a double fellowship trained, double board certified reproductive psychiatrist. She went to medical school at Ohio State University, her psychiatry residency at Cleveland Clinic, and she has an addiction psychiatry fellowship at Yale, where she focused specifically on the treatment of addiction in women. And she completed her perinatal and reproductive psychiatry fellowship at Northwestern University. Wow. Currently, she sees patients via telehealth in the state of Illinois.
Welcome to our show, Nia. Would you mind telling us a little bit about your cultural background as well as share with our listeners about how you got into medicine, specifically reproductive psychiatry?
Sure. Thank you so much for having me. So I was born in India, in Punjab, India, and lived in India until I was 4 years old. My mom was pregnant with my little sister, so we kind of rushed out here at that point. So I did all my schooling and education out here. I grew up in Ohio. Started looking into medicine really after a tragedy in my own family. My dad passed away when I was quite young, at 13. And I started volunteering at the hospital that he passed away in order to connect more with his passing, because I wasn't there when he passed away. And that was the main way I could see myself being able to connect with his death, being able to connect where he last took his last breath. And no one in my family was a physician. It's kind of surprising for an Indian family because literally everyone is in medicine, but no one in my family was. So that was not pushed upon me in any way, nor was it encouraged. It was just something I kind of just found my own way to. I started volunteering and then was thinking, well, I'll either do research maybe, or maybe I'll become a nurse or a physician. And then just worked really hard through all of high school and then was pre-med in college. So at Ohio State, I studied microbiology and did a lot of lab research as well, and realized, gosh, I'm just terrible at research. I just can't make progress on it. I could study well, I could take tests, but research, was soul sucking. I need human connection. I need to be able to connect with people, talk with people. And so that's really where I also found my path to psychiatry, because I would spend so long in patients' rooms on my medical school rotations. And part of it also was that a family member of mine had gone through depression. And this happened while I was in college. And just seeing how it was managed, not really recognized until way too late, really affected my interest in psychiatry. Because when I went back on my rotations in medical school, I saw what a profound impact it can make when people are treated for this, and how little our community understood or even knew about that. And that's how I found my path to psychiatry.
Could you maybe explain to our listeners what is reproductive psychiatry?
Yes, yes. So reproductive psychiatry is psychiatry during the premenses or like menses, prenatal, pregnancy, loss, postpartum, and menopause phases of life. So really kind of focusing on the effect of hormone and the effect of women's reproductive life cycles on our mental health. Because it is very different. And it's something that we actually don't learn enough about in our general psychiatry residency. So I got exposed to it in general psychiatry because my mentor was a reproductive psychiatrist, and I also like sought it out specifically in my fellowship just because I thought women with substance use disorders were just greatly misunderstood, and the reasons for why their substance use perpetuated and continued were not being addressed adequately. And so that was something that I felt passionate about addressing. But reproductive psychiatry itself was something that I went into further with another fellowship, mainly because I think it's really important to get as much information as we can. And the information we have is ever evolving. There's studies coming out monthly every year, and staying on top of that research is so important in order to inform our patients in the best way that we can.
And I think you have shared before, like some of your personal journey also might have affected or driven your passion for this too. Can you share a little bit about your motherhood journey? I know the topic of this discussion is more on medications, but
Yeah.
I'm sure our listeners want to know, kind of your connection to it
Yeah.
too.
So I started practicing reproductive psychiatry in residency as a third year. You have to wait till you're like a senior year in residency to really start like getting more immersed in that, because it's outpatient only. I loved it. I mean, it was something I definitely felt connected to, but I was already like determined to do my addiction fellowship. It was something that I got an interest in early on, so I went and pursued that. And then I focused on like, treatment of women in my addiction fellowship. The reason I went back to do a second fellowship, even though I had thought about it, doing it like right after the first one, was I went through a really tragic pregnancy loss in 2020, where I went through a 21-week loss. It really affected me. And I think I just felt really lost personally. I felt like I didn't understand why something like that would happen. I mean, I was like prepared for a lot of things in my life. I really wasn't prepared for that. And for me, going back and doing the reproductive psychiatry fellowship was like a way for me to reconnect with what I felt like my life was guiding me toward. That I was going through this for some purpose. And if the world didn't have a purpose for that, I was going to make a purpose for that. And so I went in and did the reproductive psychiatry fellowship kind of crazily after I was already in practice for 3 years, and did that while I was still working as an outpatient psychiatrist. So I worked like insane hours. I was also doing IVF at that time because I had infertility, and it all just kind of came together. And the same year that I graduated my reproductive psychiatry fellowship, I had my daughter. So it was like a very beautiful, like coming to life moment for me. Like so passionate about what I do, and it's very like heartfelt connection to it, like for myself.
Thank you so much for sharing that. It's, our journeys to being mothers really difficult. And especially as female physicians, I think too, what we've heard is that 1 in 4 female physicians suffer infertility. And, you put so much of your heart and soul into your work and helping other people, and then you kind of get left behind too. So
Totally.
thanks for sharing that.
Of course. Thank you.
One of the most common myths that we hear is that moms have to stop breastfeeding if they go on psychiatric medications. I'm going to put that in quotes. It's not true. In fact, in one of our other episodes, I believe it was episode 9 with J.S. Park, he actually tells us that his wife apologized to their baby when she decided to start an antidepressant because she would have to stop breastfeeding her baby. So, it's things like this just feel like, oh, I wish they had had more information or somebody had been on board to help guide them through this. So can you tell us a little bit more about safety and efficacy of most antidepressant medications while breastfeeding?
Yes, definitely. That made me so to hear about just the apology to your baby to take care of yourself and your health. And one, it like was so most likely unnecessary. I don't know what medication she was on, but I hate that this myth is so common. You do not need to stop breastfeeding on most antidepressant medications. In general, most medications like that are antidepressants have a pretty low RID. So RID is a concept called the relative infant dose. And what that is it helps us estimate the infant drug exposure based on comparing the levels found to like what the mother is taking, levels in breast milk relative to the mom's dose. And it's expressed as like a percentage of the maternal dose. And generally speaking, an RID of less than 10% is what we're looking for when we're looking at like the compatibility of medications with breastfeeding. Almost all of them, certainly all SSRIs, are less than 10% RID, much less than 10% RID. And so a lot of medications exist where you can breastfeed safely on, not have to worry too much. So, the very low amount of the medication is even getting into the breast milk. Secondly, though, antidepressants, specifically SSRIs, have been very well studied with breastfeeding. And so they've done a lot of research looking at the exposure of infants to SSRIs from breastfeeding, and they have not found any sort of negative outcomes to come from that, any kind of long-term development negative outcomes, such as changes in IQ scores, cognitive or physical development changes, or any sort of predisposition to like behavioral health or like mental health diagnoses as a result of breastfeeding on antidepressants.
Yeah, I think that's so important to emphasize that you have this. There's this thing too that, there's a risk of untreated illness versus taking the medication. You have to sort of weigh that, right? People who are not treated for their mental illnesses, there's also risks to their babies if they don't treat that. And sometimes it's actually higher than the risk of being on a medication.
Right.
So I think it's important to highlight that difference.
There's just so many myths about breastfeeding in general, like not even beyond medications. There's always like the saying that you're not like a blender. You're not making some sort of smoothie with things that you're putting into your body, that very little of what you're putting into your body is going into the breast milk. So even things are like, oh, I need to stop eating this, and this food, and it goes with the medications as well.
Totally. And I mean, I don't know if you guys have had the experience, but like in Asian cultures, at least in my Indian culture, there was so much like misinformation around you can't eat this when you're breastfeeding. You can't have anything spicy when you're breastfeeding. It's like, yes, you can. Yes, you can. Just eat.
That reminds me of, I think in Peggy's episode, you were saying like, in your postpartum confinement, your mom was like, you wanted ice cream, and your mom's like, no, you can't have ice cream.
Yeah.
Like, just certain myths, right?
Mm-hmm.
And I think another topic that comes up is that some moms who had been on medication before pregnancy, they might suddenly decide to stop taking their medications cold turkey because they don't want the baby to have the medication when they're in utero. So I'd like if we could talk a little bit about the risk of that untreated illness versus the risk of medications when it comes to things like, miscarriage or preterm birth or neonatal death. Those are kind of things I think a lot of moms are worried about when taking medications when they're pregnant. Maybe you can shed some light on weighing the true risk versus benefit of medications.
Absolutely. Just to quickly go back to the breastfeeding piece, I forgot to mention one really good resource for anyone who's curious about like their medication and if its compatibility with breastfeeding. LactMed is an incredible resource available online. If you just Google LactMed, LACTMED, it's originally like that. Now it's through the NIH website, but you can look up your medication on there, and it has a lot of data that, like, almost all the data we have with breastfeeding on those medications. And that's really much more reliable than Google.
And we can put that in our show links as well. So
also want to throw in that when I was doing my PMHC studies, they emphasized, you mentioned a lot of studies have been done on SSRIs in pregnancy, breastfeeding. Of all medications, I want to say they are probably the most studied in pregnant women breastfeeding. So there's the most data on this. So I would say some people are like, oh, there's really not enough data, but really for this specific subset, SSRIs have probably the most data and research on that. So
Tons of data.
Just want to clarify.
Yes. But yes, so the risk of untreated depression is something that women often don't think about when they decide to come off their medications. And sometimes they're even told by sometimes a psychiatrist or their treating provider, like, sure, when you get pregnant, just stop the meds. Then we like risk the mom's health in that first trimester. And the risk of relapse is really high if you like immediately discontinue an antidepressant cold turkey without weaning and giving the proper time to really evaluate it. And the risks of depression are significant to a pregnancy and are certainly also have postpartum risks with it as well. And a lot of people are thinking about, the risk of the medication, but we do have to weigh that against the risk of the condition. A lot of the early studies that were done on medication and SSRIs in pregnancy were flawed for that reason. Women who had depression taking SSRIs to women who had no history of depression, no history of anxiety, not taking SSRIs. So you're not comparing apples to apples at all. And really, some of the more newer and more refined studies have a lot better like comparison data to look at, and it really has helped us understand that there's some risks that are there. I'd love to cover those. So, in terms of the risk of untreated depression, there is a small risk of miscarriage that's associated with untreated depression when you're pregnant. And that is not there when you are on like an antidepressant, for example, like an SSRI specifically. There is also a risk of preterm birth and low birth weight or small for gestational age babies. And that's there regardless of whether or not you take medication. It's also there when you take medication, but it's there if you don't take medication. So that's one of those risks I tell people you have it either way. Just from having this condition, which you can't help, it's not your fault. We all have certain medical problems and we all carry certain risk factors because of those medical problems. And those are just two of them that come with that. And there's also a risk of the mom not doing well through the pregnancy, thereby causing perinatal complications. And there was actually even a study that showed that there was an increased risk of C section delivery just from having untreated depression in pregnancy.
I mean, there's the other thing that I think people sometimes forget about is when you are depressed, when you have prolonged stress in your body, that stress, and maybe you can't measure it, but that stress is increasing like your
Yep.
cortisol. It's increasing like methylation of fetal genes that can affect, their receptors, and that can increase the risk of preterm birth because you're stressing out the baby when you're inside. So really treating your mental health so that mom is not stressed, that goes a long way too for the babies. I think that's something people can have to like remember and think about too.
Totally. Your environment changes when you are depressed. And so keeping yourself well, having lower kind of cortisol levels, having lower like circulating inflammatory like cytokines, all of those things are really important to maintaining your pregnancy's wellness too. And I think it doesn't get as much light shed on it just because we don't have all the information to know about it. But certainly we know for adults, even that are not pregnant, that this is something that happens. With the risk of untreated anxiety, even. It's been associated with preeclampsia, gestational hypertension, preterm birth. So that's just from having high anxiety in pregnancy and not being on any medication. So these conditions aren't benign, and so treating them with something that's going to make you feel so much better. And certainly, like yeah, treatment infers some risk as well, but treating them oftentimes is way worth the trade off.
Can you talk a little bit about the like side effects? I think some moms are worried about like, being on it and then once the baby's delivered, like the neonatal side effects once the baby comes out. Some people I think are worried about that and there have been reports of like neonatal side effects. Can you talk a little bit about that and maybe like the numbers or increased risk?
Yes, definitely. So going back to like the risks of the depression in pregnancy versus the risk of SSRI in pregnancy. So I kind of mentioned that there's still preterm birth risk with SSRI in pregnancy. There's still a risk of small for gestational age babies. There is no risk of birth defects. That's a huge one. And that's including cardiac birth defects when they've looked at studies like in more detail over time. From background risk of like 3 to 5%, there's no increase from that. There was a very small risk of increase with a medication called paroxetine. And since then, they looked at it's a smaller risk than we even originally thought it to be. With the SSRI exposure in pregnancy, the main differences that are going to stand out are going to be neonatal adaptation syndrome, which I believe is what you're speaking of here, and then also PPHN, which I'll also shed some light on as well. So with neonatal adaptation syndrome, that's the more common thing that we see with exposure to SSRIs in pregnancy. So when the baby's born, there is an adaptation or adjustment period, which is self-limited and mild typically, but there's a constellation of symptoms that we look out for. And this can happen in anywhere from 0 to 30% of births from exposures to SSRIs. And those include usually mild symptoms, which are like crying and fussiness, maybe trouble with like feeding or sleeping, jitteriness or agitation. There are a few more severe symptoms of neonatal adaptation, which include respiratory distress. So baby might need to be put on oxygen just to help support and open up their like respiratory pathways, hypoglycemia or hypothermia, and then hypotonia. So those like last three are ones that probably would necessitate a remission if that happened, but it's really rare to see that as well. In most cases, neonatal adaptation is very like mild and self-limited, and typically the treatment for it is just the normal things that we'll be doing postpartum anyway: hold the baby, like, soothe the baby, skin to skin, breastfeeding. And so there's not really like a lot of intervention that really takes place to manage neonatal adaptation. The only time there is intervention typically is if they need like breathing monitoring or if there's hypotonia or something like that.
I was gonna say, like, my baby probably had fussiness, couldn't, didn't want to eat, whatever. And I wasn't on an antidepressant when I was, had her. And it's like a lot of these symptoms, I'm kind of like, that just sounds like a normal baby to me.
Yes. Yes. And actually, online, sometimes if you look it up, like you can be biased by the way you look something up, right? So if you say, like, can my baby withdraw from an antidepressant? You might find a lot of answers that say yes, but it's actually not thought to be a withdrawal at all. And I having been someone who studied opioids and opioid replacement in pregnancy, so that is more of a withdrawal that we see in a baby when their babies are born to moms who are on MAT with opioids. And there's a different way of managing that. But with antidepressants, it's not actually a withdrawal. It's some sort of like adaptation and some from the serotonergic signaling that happens when the baby is born, and they will adjust. It just takes them a little bit longer to adjust. When they've looked at studies where they have stopped the antidepressant, because some moms are like, well, maybe I'll just stop my antidepressant in like, third trimester. And they've stopped the antidepressant in third trimester, and that neonatal adaptation still happens. So there was really no need, because it wasn't a withdrawal in the first place. So that's not recommended because we don't actually see that it lowers risks by stopping it in like the second or third trimester either. And then the PPHN, that I know gets a lot of discussion because it is a more serious condition, but I'm happy to like talk about it a little bit more here too.
Yeah, we can talk about, I think the numbers are, I mean, if you kind of break it down to the numbers, yes, it is serious, but actually the increased risk from the baseline patients or, babies that might have it, it's actually very small, right?
Totally. So PPHN is persistent pulmonary hypertension of the newborn. So that is a pretty rare but serious condition. And it happens when your newborn's like circulatory system doesn't adapt to breathing outside of the uterus. And so you get like shunting essentially because there's pulmonary pressure where the blood is supposed to flow into the pulmonary like circulation, and there's pressure there. So instead it goes to a different pathway in the heart and goes to the body deoxygenated, which is not good because we need the body to be getting oxygenated blood. And so that is something that's managed in the ICU with more advanced measures. But it is really rare, Jasmine. You're right. The risk of PPHN in the general population is 20 out of 10,000. So a general like risk of like 2 out of 1,000. And it goes up with SSRI exposure so far, like that we know of, to 29 in 10,000 cases. So a total increase in risk to like somewhere between like 2 and 3 to 10,000. So it goes up by a net increase of 1 in 1,000 for the net increase in risk. And actually, there was a new study that was just published in January of 2024, which I thought was great because for the longest time, we've been looking at a rare condition and trying to figure out what exactly are the risk factors for this really rare condition is hard because we're not doing prospective studies. This is all retrospective studies that we're looking at and trying to understand based on what we have. And the study that was published in January 2024 showed that there was a slight trend towards an increase of pulmonary hypertension, but it did not reach statistical significance. And after adjusting for other risk factors and maternal factors, they found that more than 3,000 infants would need to be exposed to an SSRI for an additional 1 case of persistent pulmonary hypertension.
So it's a lot less than people actually think, but it's just something we need to, disclaim as we should. So this is not to scare anyone, but just to let you know, like if you actually compare the risk to the general population, right, the increases is small.
Exactly.
So I'm going to be honest, as I listen to all this as a not medical professional, it is a lot of information. So I imagine as a patient, like what is that process like to decide when and what medication to start treating moms with? Like, let's say I'm a mom listening to this right now and I'm in the heat of it. And either I'm pregnant and like not sure what to do, or maybe it's postpartum, not sure what to do. And I'm listening to the risks and benefits, and it's a lot of information. How do you start that process? What is that conversation like? How would they start that? Because there are many different perinatal mental health disorders, but if we were, let's say it's specifically depression and anxiety, because even I had a lot of anxiety in my prenatal and then in my postpartum.
So my favorite time to see a patient is typically before they're even pregnant. And even maybe they're not even like they're still on their birth control or they still on their IUD. And that's totally fine because that's when we can get into the planning stages and talk about all these things, have ample time to discuss it and not feel so much pressure. But certainly at any point, I'm happy to see someone. If you're in the middle of your pregnancy, end of your pregnancy, immediately postpartum, it is overwhelming. And I think that we have to have like multiple appointments to discuss. It's so much information that it almost feels overwhelming just to hear it. And you just want to shut it all out and say, I'm not ready for this. But it's just one step forward and getting more information, then discussing it, digesting it. I will often give my patients the information at the first visit. I'll send it to them, let them review it. I'll have another visit within a week where we discuss it together. I'll maybe have another visit where I discuss it with their partner just so that they don't have to be the one to answer their questions. So by the end of it, it starts to feel really familiar. And then say that that was in preconception. And then I like worked with that patient for about a year before they got pregnant. And then they all of a sudden get pregnant. Guess what? Then when they get pregnant, I'm like, hey, let's refresh that information that we discussed like a year ago since it's been a while. And at that point, you've heard it so many times that you're like, yeah, I remember that. So it becomes less and less overwhelming.
And I guess the other thing is like, when do you decide a patient should actually start medication? Because I think a lot of patients, especially Asian patients, are like, I don't want to use medications. I don't need medications. Do I really need the medications? So how can you have this discussion to say like, this is a time when I actually think it would be beneficial for you?
Yeah, I take a lot of time to understand what this person's baseline functioning was. Like, how were they doing when they were well? When were they last well? Have they been unwell for a certain amount of time? And has that become their normal? And really kind of evaluating like, where's their quality of life? Can they feel joy? Can they feel like good feelings? Do they feel balanced? And why are things feeling so dysregulated or disrupted? Once we understand all of those things, people start to understand themselves as like, wait, I'm really not well. Like I've been lying to myself, gaslighting myself or whatever into thinking that I'm okay when I'm really not. It's not just going to get better from positive thinking or whatever it might be. Then we start to have those discussions about onboarding a medication, and the right time is different for everyone. Some people have a point that they need to get to where they feel like, okay, now is the right time. I often don't want to see things get to a point of like ultimate hardship before we start something, because it does take time for a medicine to really like start working in your system. It takes several weeks, and so starting it in crisis can be challenging. Doesn't mean it can't be done. It's just a little bit more of a challenge.
And I often hear patients will say, oh, I hear that Zoloft is the one that I should try. Like a lot of people will say that I heard that's the best one because, maybe it's the least amount in breast milk and do you really believe that that should be the first choice to try, or are there any other good options? I just want to put that out there because I hear this question so much.
Same. It comes up all the time with my patients, especially like patients who aren't on Zoloft, right? Or like haven't done well with Zoloft. So just to kind of like give an idea, like so Zoloft is a go-to just because there's so many studies on it and it's been studied a lot, like in isolated studies too. So we have a lot of data on it. But having more data should not be misconstrued with safety specifically. It means that we have more data on the safety. It's not the same as us saying it's the most safe because we don't know that. We just have more data on it. And really, Zoloft does have a really low RID through breast milk. But as I said earlier, like all of the SSRIs have a relatively low RID. Fluoxetine out of the SSRIs, which is Prozac, has like the highest RID, and that's still less than 10% and it's very compatible with breastfeeding. And so I don't allow that to be like the main reason I make a decision on the medication. I look at specific factors like how has this person responded to medicine in the past? Did they previously try Zoloft and didn't do well on it? Do they have a family history of like a really positive response to a certain medication? Like, I mean, I swear I've seen some patients who like their mom, their sister, both of them did great on Lexapro and they feel more comfortable with it. And I feel more comfortable with it because I see that there's a genetic kind of response to this medication that's there as well. Sometimes we can also run some additional tests, like gene site testing is a looking at like someone's genetic risk factors or genetic factors and assessing like how their body's processing medications to be able to identify what medication might be like more ideal for them. It's not a great test and it's not without its own flaws, but it is definitely something that can help guide us sometimes as well. But Zoloft definitely is not like the only medication you can take. There's so many medications. Zoloft just has a little bit more data.
Yeah, thank you. That's a great explanation. And then another question I get a lot. A lot of moms will tell me or ask me, like, how soon can I get off of this? Like, as soon as they get on, they're kind of like, okay, I'm doing okay now, I think. Can I get off of it now? So I think a lot of the worry comes from, like, they say, am I going to be dependent on this antidepressant? Is it going to change me, or is it going to like alter the way my brain is, right? And from what I have learned, I've asked my own psychiatrist about this, is that no, you can't be addicted or dependent on an antidepressant. I've never heard of any of that when I was studying it in pharmacy school. But how do you approach someone who's really worried about being on an antidepressant for too long?
This comes up with almost every like South Asian or Asian patient of mine, truly. And I think it's just the stigma is so intense in our population and in our background that it informs these kind of misguided perceptions of how we should perceive or that we should be on it for like the shortest amount of possible. And so this is really individualized too, but I usually tell people like the target is about 1 year. When we start to be on it for about 1 year from when it starts to help you. So some people will think about like, oh, from 1 year when I started meds in general. No. Say you started one medication, say you started with Zoloft and it just was awful for you. And then we switched you to a different medication and you started doing so much better after a month. So that point is like where we count that 1 year from. And then let's pretend you were also, pregnant during that time. So then you would be 3 months postpartum at the 1 year mark. So that's not the best time to offboard a medication because 3 months postpartum, you're still not sleeping, your hormones have not regulated, your breastfeeding hormones are readjusting. And so I often look at it as a 1 year asterisk because we have to figure out when that 1 year time point, like 1 year is the shortest, but we also want to target it at a time that makes sense when things are calm. Maybe like in postpartum, I'm looking at almost like 9 to 12 months postpartum is when we consider if you really want to offboard the medication, that's when we start. And sometimes women decide, like, I feel so much better. Like, I didn't know that I could feel this good even before pregnancy. And do I have to come off of it? And I get that question a lot. And you don't have to come off of it. There is no risk of having an addiction to an antidepressant. And I will say that as someone who's studied addiction extensively, it does not light up those regions of the brain at all. And so we don't develop a tolerance to antidepressants. This comes up a lot because sometimes people say, well, it was working for me for a while, but then I had to increase it. And then it was working for a long time, then I had to increase it. So maybe I'm developing an addiction. And the answer is no. But think about what we're treating. Each depressive episode is not the same. Each anxiety episode is not the same. For example, perinatal OCD or intrusive thoughts are not the same as generalized anxiety symptoms. And so doses of medication may need to be adjusted over time to reflect treatment of whatever current episode you're in. But that's not because you have an addiction to it.
Oh, I love that you said that. And the fact that you have like kind of the background in the addiction medicine to like definitively say like, no, you're not going to get addicted to it. And I actually had, I met a mom friend who's a pediatrician, and she had told me that she started developing depression after she stopped breastfeeding because a lot of the mood changes and hormones would drop again. And she said she actually started Zoloft, but she goes, oh my God, I've never felt this good in my life. Like I didn't even realize this might have been the missing piece all my life. And she never wanted to get off of it. So, I think I share that story a lot because it just kind of highlights that, like, it's okay if you have to be on this for a long time. If you want to be on it lifetime, some people are on, diabetes medications for their entire life because it helps them function. But that doesn't mean mean that your character is bad or something if you have to take something to help your mental health, right?
And you never hear someone say, I don't want to be addicted to diabetes meds. Like it's weird that they associate medication for your mental health with addiction when it's like no one says that about any other medication that helps your body. You know what I mean?
Right? Or that it's even seen as a character flaw or some sort of lack of fortitude. Totally has nothing to do with that at all. This is a condition, this is a medical condition, and it deserves to be treated as such.
I think that's what I'm hoping too as we have all these episodes is like, how do we let people understand that it doesn't make you weaker or lesser than it's health? This is a medical condition. These are diagnoses, like we've talked about before, this is a disease that you're treating, and yet there's just so much stigma around the medications.
And the medication part, I think some people, when they hear us talk about this, they feel empowered, and other people, they get scared to even start medicine, right? Because they're like, well, I don't want to be taking something forever. And so I always tell my patients, like, look, these are my recommendations. This is what the general recommendation is. But if at any point you say, I just want to be off and that's my wish, I will help you come off of it, right? I always tell them, like, you're taking the medicine. I'm prescribing it, but you're doing the work. You take it every day. And so if you decide that you don't want to take it, tell me. Don't stop it on your own. Let me help you get off of the medication. And that way we can reestablish, like, what's your baseline and see if you want to take it again or if you want to take a different medication.
I remember also too, when I used to work inpatient psychiatry as a social worker, there's also like, it's not just the medications, it's also the therapy. And how do you work with those together if you are coming off, to make sure you're not just, it's not a magic pill. You do put some work into it. I always used to say the medication might help lift the cloud so that you can have effective therapy, but they do need to go hand in hand a lot of the time. What would you say to a new mom who's experiencing perinatal mental health disorders, who are considering going on medication or considering seeing psychiatrists? Because as I've been listening to you, I'm like, I bet there's moms listening thinking like, oh, I wish she was my provider. And a lot of times having these kind of difficult conversations with an OB, maybe not everyone just has a perinatal psychiatrist. So it's like, let's say they want to start this conversation, but their only provider is the OB. And how do they even get it? And not that the OB can't have it, but I imagine you have way more wealth of knowledge specific to this, and that it might help a mom better to say, I actually kind of need to go see a psychiatrist to have these conversations.
A postpartum mom should think about what she wants in her doctor first. If you are looking at someone of a certain background, certain age range, just things that you would feel more comfortable. It's someone that you're going to want to feel comfortable speaking to and that has the background and training. That's really important because depending on who you see, you're going to get different avenues of advice and recommendations. And you want to make sure you see someone that has a training and background to support the recommendations that they're giving you. I often will recommend people to look on PSI's directory because people who have a PMHC or people who haven't done a reproductive psychiatry fellowship will list their profiles on there. Psychology Today is another great website to look at because you can sort and filter by like reproductive or women's issues, and that can help like start your search as well. When you're looking for someone, you have to also consider, you know, and because wait timing, because sometimes it takes a while. Now, for me, it usually doesn't take that long to get in with me. Usually, people can get in with me within about a month because I leave some slots open specifically to see new patients. But you want to make sure you give it time. And so, if you're even thinking about meeting with someone or making an appointment, err on the side of just making it. Even if you're not even sure if you're ready, if you feel like you might cancel it, that's okay. Just make the appointment. And as it approaches, like that's one less thing for you to worry about that you have to reach out at that point when things are really bad. If things are starting to feel worse, make it then. And I would say, like, I did the same thing when I was like searching for my fertility doctor, for example. I didn't know if I needed a fertility doctor, but it was like, 7 months in and I kind of knew my body. I knew something was up and I made the appointment. And then as that appointment approached, I kind of knew, well, yeah, I definitely need a doctor to help me with this. But I also didn't feel as overwhelmed because I had already made that appointment.
Are you able to do like virtual? Because I imagine some things that I've heard, in a lot of our guests have been pandemic moms, but even just the barrier sometimes of leaving the house to see a provider. Can they see a psychiatrist virtually?
Yes. In fact, I practice almost exclusively virtually, just because I work with women who are pregnant or postpartum, and you already have to take out so much time of your day commuting to and from other appointments. And you. So you can just be on Zoom and it's totally fine. In that way, our access to care expanded greatly post pandemic, and it's really changed the way in how we deliver care and it's made accessible. Because, say, I'm in like Chicago area, anyone in Illinois can see me right now. They don't have to be anywhere near Chicago, they could be in Southern Illinois. As long as your doctor is licensed in the state in which you're located, they can see you.
Yeah, and I often tell people that it's not a bad idea to get set up before you deliver, during your pregnancy. If you want to set up with a therapist, like just in case, for postpartum, it's so hard to do that legwork when you have a new baby on board
Yeah.
because you're just so busy trying to like stay afloat. How do you have time to like research somebody that you know is going to be compatible with you or not? Do that work up front, and like you said, just sort of pre-schedule that, screen somebody before when you can. I know Peggy did this when she was pregnant, that found somebody that she wanted to connect with like after she delivered. Like set it up just in case. Have give yourself a safety net, right?
If you end up not needing the provider, like that's fine, but better to have that set up and even get that one appointment postpartum. And maybe even you have that one appointment postpartum, you think you're like don't need it, and then maybe 3 months, 4 months down the line, you're like, oh, I actually need them again. Like it doesn't hurt to do that.
Totally. And it helps to get that intake appointment out of the way. I often will tell my patients that the intake appointment feels like so many questions, and it feels kind of regimented because I have to get so much data and so much history from you to be able to understand the recommendations that I give from that point. And it's a lot of information gathering. So it doesn't feel as free flowing as a typical appointment would. And so usually I'll do the intake, I'll do another appointment. And then even if we're not starting any medications, at least I know you, I know your history, I know what I'm going to recommend, or I know how to approach your care at that point. And so that rapport is built up. It doesn't feel as daunting. But people are so scared sometimes, like they like really anxious when they come and like, sign on for their appointment with me. And I'm like, I'm just another woman. You and I are here together. Like I'm not up here and you're here. Like we're here on the same kind of wavelength, I'm just getting you the information you need so that you can make some of the decisions that could be valuable in your care.
I think it's helpful also to have, like you mentioned, the background. You have the same cultural background. Knowing that someone is a mom, that you've been through this too, that can be helpful too. Like for me, the first, one of the therapists I had was like a young, 20 something year old about to get married, therapist who's like, "Oh, I've had anxiety." And she was like, kind of gave off the vibe like she never wanted to be a mom. And I'm like, why are you my therapist? Like, this is not a good fit. And not to brush off people who are just coming out and practicing. It's just that wasn't a good fit. She wasn't Asian. She didn't really understand my cultural background either. Um, I'm going to throw in one last question and um, see how you want to take this. But are there any alternative medicines that you think are safe to supplement, or would you recommend against it at all? Because Asian people are all about like, let me just try the natural remedies. Is there anything that you think is maybe actually research based evidence to be good suggestions that people can try?
Yeah, actually there are. Making sure that you check your vitamin D level in pregnancy and throughout pregnancy can be really helpful if you're not taking an antidepressant. Even if you are, it's important to check because vitamin D levels can be very low in Chicago, at least. A lot of people are vitamin D deficient. And so there's a certain level that you can take up to in pregnancy. In pregnancy, you can take an additional like 3,000 units of vitamin D3. But you want to make sure you check your level so you're not going over like the, levels that are maximum. Another thing that is really well studied for treatment of depression in pregnancy and is not medication is light therapy. So often, light therapy is considered for seasonal depression to be using in the morning for about 20 minutes, as it's about like the laptop distance away from you. And it can be really impactful for seasonal affective disorder, but it's also been studied for perinatal depression when it's non seasonal and can be helpful for focus, cognition, as well as energy level and mood. So that could be something that's effective as well. I really don't know much about some of the like Eastern treatments or like Ayurvedic treatments, and I don't know much about their safety in pregnancy either. It's just something we don't study, so I feel like I can't comment on that.
Okay. But those are still good suggestions. So thank you.
Yeah, absolutely.
Yeah. Okay, well, thank you, Nia, so much for your time. We are gonna link some of the things you might have mentioned, like resources. And do you want to say like where people can find you online or your practice?
Yes. So I'll have you link Mother to Baby and LactMed for people so that they can look up information on there about medications and breastfeeding as well. And then I work at a practice called Meridian Psychiatric Partners in the Chicago area. Like I see most of my patients I see virtually, and I'm licensed in Illinois. So patients have to be located in Illinois to see me. And then you can also find my profile on the PSI directory. I'm searchable on there.
We'll link all those.
Yeah. And the
Thank
link
you.
to the practice is in my Instagram as well.
Great.
All right.
So, yeah, we usually wrap up our episodes with everyone kind of going around to share one thing that they maybe are thinking about doing or have done this week for their mental health, just as, maybe little tidbits for our listeners to have some inspiration. So, I don't know if you have anything or if any of us want to share something that they did this week. Yeah.
I have a great one, and Jasmine knows I literally just did this today, is I asked for help.
That's huge.
I was feeling really overwhelmed with a particular task and feeling hesitant to ask for help in it, and recognizing that it doesn't reflect on my own worth or my value to ask for help, and to also trust that when you're asking for help, it also is strengthening the relationship with the person you're asking help from. So that was mine for today. I didn't think I would have that be my thing for today, but it literally just happened. I was like, this is a great one. And I figured I would share it.
I love that.
I love that.
So I have a doozy of a morning tomorrow because I go in for some monitoring appointments for IVF. And normally I would love to do some exercise on the weekend because I get some time for it, which I can't right now. But I'm going to do some planting. My husband and I have a garden, and so we're going to plant some vegetables in it. And this will be our first year of being able to do that with our daughter. So we're going to involve her, which will be really fun too.
Love gardening.
Aww.
Yeah.
That's super sweet.
It's very centering.
I don't have a huge one, but with this being sort of Maternal Mental Health Month, I just, I'm spending this weekend with family, and I think that sometimes with the hustle and bustle of life, it's just so hard to find time to see the people you love and the people you want to spend time with. So I'm going to use that as my try to be present and really just enjoy. And, with Mother's Day around the corner and stuff too, really just trying to be grateful and appreciate the people that I have in my life. This year's Mother's Day just feels, I was looking back, and it's literally my very first Mother's Day. It was awful because I was in the pits of postpartum depression. And this year's Mother's Day is the exact same date that it was 5 years ago. So it's kind of significant to me. Yeah. And I just feel it's so nice to reflect back that the journey has been, I'm here now on this side of it, and that I can help out other people now. So yeah, I think just practicing gratitude this week. Thank you so much for your time, Dr. Nia. I really appreciate all the information you shared. And I also appreciate a lot of the information you share online in those little clips too, because I think sometimes just little bites of information are so helpful. I know you said your page is relatively new and stuff, but I already love the content you're sharing. So thank you so much.
Thank you so much. That motivates me to do it more. Thank you.
Today's episode was brought to you by the editing support of Dr. Tony Nguyen, PharmD. When I mentioned in my self-care for the week that I asked for help, it was in editing this episode. As you know, Jasmine and I do this podcast on top of being full-time working moms, and with wanting to bring you all more episodes this month, I needed some extra support in getting this episode out to you all in time. So thanks again, Tony, for all your help.
We hope you have enjoyed Healing the Tigress in our conversations on maternal mental health in the Asian American Pacific Islander community. Please follow our show and our Instagram page to catch our latest episodes. We have so many fantastic guests and deep topics that we are so excited to cover soon.
If you enjoyed this episode or would like to support us more, please leave us a rating or a review and share this podcast with a friend to spread the word. Check out the show notes for more links. Thanks for joining us today, and we hope these conversations will help our AAPI mothers heal their inner tigress and honor their mental health as they deserve to. See you next time.